Morning everyone, welcome to Unacademy where you can crack all NEET PG exams with us with our top educators, quality content and have a great learning experience. So guys, let's crack NEET PG. A little about me, I'm Dr. Sasha Menon Remedius. I've done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore, and I have two publications and one paper presentation in the field of anesthesia. And I've been working in Bangalore for the past 2.5 years. Today's topic will be oxygen therapy equipment or devices, and we will discuss in detail. Basically, it includes such as your non-rebreathing mask, your oxygen mask, nasal cannulas, etc. We will be discussing all these. So, little about Unacademy. It's one of India's largest online learning platform where you can get plus subscription and access to unlimited live and recorded courses from India's best educators. So, what will you get out of Unacademy? So, basically, at Unacademy, you can we have our daily life classes, right? So, when you go to a coaching institute, you have to take the trouble, you have to get up, get ready. There's a lot of energy waste, time waste. Once you get there, your educator has to be able to clear everyone's doubts. It's not always possible for him or her to clear everyone's doubts because because these are large classes and they have a stipulated amount of time and syllabus to cover and all that. But here at Unacademy, you can chat with your educator, engage in discussions, ask your doubts and answer polls, and all this is while the class is going on. Then we also have a all these courses are structured courses, that is, the educators have researched and based on what is required for you all from NEET PG point of view, your topics have been prepared and based on that only classes are taken. Then we have our live tests and quizzes which evaluate your preparation. So we, with our live tests and quizzes, we evaluate your preparation on a regular basis, right? So we also, y'all also, basically it's for y'all to evaluate your preparation, as on this platform we cannot really evaluate your preparation, but yes, it is basically for y'all to evaluate your preparation. Then we have you have unlimited access, so one subscription can get you access to all our live and recorded courses and you can watch from the comfort of any of your devices. These are some of our top educators: Dr. Nikita Nanwani, Dr. Mohammad Assam, Dr. Devesh Mishra, Dr. Preeti Sharma. Dr. Nikita Nanwani is a NEET PG mentor for radiology as well as mnemonics and concept focusing on must-know topics. So those of you who feel mnemonics is helpful for you all, this is ideal. Not the way Dr. Nikita has prepared, as well as if you could prepare your own mnemonics, it's even better. These are some of the courses that are offered in the various subjects. There are about 19 subjects or so that you'll have to cover. I know these are not easy subject. It's not easy. NEET PG is not easy. It is quite difficult, but you have to do it, and we are here to help you do it. And as you can see, these are the various subjects that you all have to do. So subjects like anesthesia, psychiatry, radiology, dermatology, you all didn't have to go very much into detail, right, into these subjects during your MBBS. Over here, you need to go into some detail to be able to answer the MCQs that will be given during your NEET PG. Now, like in MBBS, you all didn't have to go very much into detail. Even over here, it's not that much of detail that you all need to get into, right? It's not that much of detail because it's still just 11 marks are allotted to these. So they also don't go into very much of detail, but they will ask you questions where unless you read and revise a little, you might not be able to answer those questions. Whereas your physiology, anatomy, pharmacology and all are allotted 44 marks each. So now these 44 marks each These 44 marks each. So they are allotted 44 marks each. So these 44 marks each, that you will have to go into very much detail, right? Because detail in the sense, they can ask you anything from anywhere. These are subjects where you all have spent a year or so studying, right? So they can ask you anything from anywhere in these subjects. So you all might have to go into some detail into these subjects. These are some of the ongoing courses on our platform: course on neurophysiology, GI surgery, cardiovascular thoracic surgery, pathology, respiratory system, course on the larynx. Then coming to the subscription part of it, as you can see, there are 5 types of subscriptions on your screen. I would highly those of you who are giving NEET PG this year, the 6-month subscription actually should suffice. For the rest of you, I would highly recommend the 12 and 24 months for those of you who want to take some time off. These are really good subscriptions, and these are really good subscriptions, and they will be very helpful for you all. Firstly, they're economical, so it's a one-time subscription. So after 6 months, if you don't get your subject, or if you want to give your NEET PG again, or if you don't clear, you will have to pay again. But with your 12 months, you have the buffer period. You don't, 12, 24, you have the buffer period. Then also with this time, the 12, 1, 2 years gives you time to think about what you want, right? So the subject based, you might have decided that you want something, but it need not be. So when you are studying, you actually get a better idea on subjects. You actually get a better idea on what you might want, what you might not want. It gives you time to think. It actually gave me time to think. You all are going to be doing this for the rest of your life. You all need to enjoy what you all are doing, right? So you have to enjoy what you all are doing. So for that, you need to so you all need to enjoy what you all do. When you all are going through each subject like this, you all will get a better idea of what is happening, and maybe your likes and dislikes will change. So if you use my code at the bottom of the screen, SASHA, you can avail a 10% discount. So as you can see, in the 24 months, there's nothing wrong in dropping a few years. Nobody will ask you any questions. So take your time, drop a few years, 2 years, nothing will happen. Nobody, if you all need the time, take it. It will only benefit you all. Again, use my code to avail a 10% discount. Now we'll move on with the topic of today. Which is your oxygen therapy devices. So basically, why do patients need oxygen therapy? So the question that arises is why? What is the need of this oxygen therapy? Yeah. So basically, the American College of Chest and Physicians and National Heart and Lung Blood Institute recommended the following cases in which you have to institute oxygen therapy: cardiac and respiratory arrest, hypoxemia, that is when your PaO2 is less than 60, SaO2 is less than 90, hypotension when BP is less than 100 millimeter of mercury, low cardiac output. So basically it is when do you give why more than why is when. So when do you give is cardiac or respiratory arrest, hypoxemia, hypotension, low cardiac output, acidosis, respiratory distress. When do you, so these are the conditions when basically cardiac respiratory arrest, hypoxemia, hypotension, low cardiac output states, metabolic acidosis. So what is it now? What is this hypoxia and hypoxemia? So hypoxia is lack of oxygen at the tissue level, and hypoxemia is low oxygen tension in the arterial blood, less than 60 millimeter of mercury. So hypoxemia is low oxygen tension in the blood, and hypoxia is at the tissue, lack of oxygen at the tissue level. Now what? So so what are the possible causes of hypoxia? So there can be arterial hypoxemia, failure of oxygen hemoglobin transport system. There can be so arterial hypoxemia can be due to low inspired oxygen, like in high altitude, because of low inspired oxygen partial pressure, alveolar hypoventilation, that is sleep apnea, and narcotic overdose. Then ventilation perfusion mismatches. Then your failure of oxygen metabolic transport system, inadequate tissue perfusion, low hemoglobin concentration, abnormal oxygen dissociation curve. So these are all the conditions in all the conditions. I mean, few of the conditions in which oxygen therapy can be started. Now, post-operatively also, when the patient any cardiorespiratory disease, elderly patients, shivering, obesity, thoracic surgery, upper abdominal surgeries, hypovolemia, hypotension, anemia in those patients, post-operative patient control, analgesia, IP opioid infusion in these patients, you can oxygen therapy can be instituted. Now, oxygen is either given alone or in a mixture of gases, right? So, it is either given alone or in a gas mixed with air, helium, or nitric oxide. So, it can be given with air, helium, or nitric oxide. Oxygen can be administered as a partial supplement to patient's tidal volume or minute ventilation as the only source of the inspired volume. So it can be a partial supplement, only source in a gas. It can be given alone, or it can be given in gas mixed with air, helium, or nitric oxide. So there are a number of methods of classification. Okay, so they can be classified as based on the performance of the device. So based on the performance, based on the performance of the device, it based on the performance of the device, it can be classified as uh, fixed or variable performance. So fixed performance or variable. Okay, fixed is also known as low flow or variable performance equipment such as Venturi mask. And the variable performance is nasal prong and nasal prong and face mask. So flows delivered by the device, so then it can be classified based on flows. It can be basically low flow, that is your nasal prongs face mask, or high flow. So low flow or high flow. High flow is your venturi mask. So low flow or high flow, and with the patient dependent, it can be classified based on the performance, based on the flow, based on the patient. Patient dependent or independent. Dependent is all your face mask, venturi mask, and independent is your ventilators. And the degree of dependency. That is your low dependency and medium, low, medium, and high. It's classified as low, medium dependency, and high dependency. Your low dependency is basically your face mask, nasal prongs. Medium dependency is basically CPAP mask and equipment. And high dependency is your non-invasive or invasive positive pressure ventilation. So the low, oh, sorry. So the low or the, so it is classified based on the patient, based on the flows delivered, based on the degree of dependency, and based on the performance, that is variable or fixed. So low flow variable performance equipment, oxygen is supplied at a fixed flow that is only proportional to the inspired, that is only a proportion of the inspired gas. Such devices are usually intended for patients with stable breathing patterns. As ventilatory demands change, variable amount of room air will dilute the oxygen flow. High flow of fixed performance equipment. Inspired gas at a present FiO2 is supplied continuously at high flow or by providing a sufficiently large reservoir for premix gas. Ideally, the delivered FiO2 is not affected by variations in ventilatory level or breathing pattern. This is important. So, the delivered FiO2 is not affected by variations in ventilatory level or breathing pattern. So basically, when choosing an oxygen therapy device, there is something known as the peak inspiratory flow rates. So if a patient is breathing spontaneously from a T-piece with no reservoir and zero fresh gas flow, so a patient is breathing spontaneously with no reservoir and zero fresh gas flow, then all the inspired gas would be room air. So there is no supplemental oxygen. Then obviously all the inspired gas would be room air. If the fresh gas flow is increased to 100 liter per minute, then all the inspired gas would be taken from the fresh gas flow and the FiO2 will be same as the fresh gas. Now if you increase the fresh gas, so initially there was nothing, there was no fresh gas flow and the inspired air was just the room air. Then the fresh gas flow was made 100. So here the inspired gas became equal to the FiO2 will be the same as the fraction of inspired oxygen will be the same as the fresh gas. If the fresh gas flow is decreased from 100 liter per minute, there will be a point at which the fresh gas flow will not meet the patient requirements, obviously. Below this flow, the patient will entrain room air, which will dilute the FiO2 of the fresh gas. This occurs when the fresh gas flow is less than the peak inspiratory flow. So over here, like we read, here. So over here, if so one is there is no fresh gas flow, so it is only room air that is inspired. Then your fresh gas flow is made to 100 liter per minute. Okay, is made to 100 liter per minute. That is when your your FiO2, that is fraction of inspired oxygen, becomes equal to the fresh gas flow. Now this is what is inspired. Now your fresh gas flow becomes less than 100 liter per minute. Now over here, when it is less than 100, there will be a point at which it will become less than the inspired gas. So when it becomes less than the inspired gas, room air is taken, right? So this occurs when the fresh gas is less than the peak inspiratory flow. So the point at which this room air is entrained with the fresh gas flow is known as a peak inspiratory flow. Example is, if a patient is breathing at the rate of 10 breaths per minute, tidal volume is 500 and inspiratory to expiratory ratio is 1:2, then each respiratory cycle will be of 6 seconds with an inspiratory time of 2 seconds. To inspire tidal volume of 500 ml over 2 seconds, the mean inspiratory flow should be 0.25 into or 15 liter per minute. So what is this variable performance equipment and fixed equipment? So supplemental oxygen can be provided by a variety of devices. The effectiveness of each of these devices is determined by the capacity of each device to deliver sufficient oxygen the uh, at high enough flow rates to match the patient's spontaneously inspired inspiratory flow rate. In a non-intubated patient breathing in an open system, the capacity uh, of the patient's inspiratory flow will determine how um, much room air will be entrained. So if the patient is not on mechanical ventilation, the capacity of the patient's breathing depends on how much room air the patient takes in. The FiO2 delivered from the oxygen source will be diluted by the entrained room air. Therefore, oxygen delivery systems are categorized as either variable performance, that is, there is no control on FiO2. So there is no control on FiO2 or high flow fixed performance system. The variable performance equipment are patient dependent. Because whatever the change in the respiratory parameters are, the patient will receive sorry, the patient dependent such that the patient receives whatever the patient receives will change with change in the respiratory parameters of the patient. So the patient will receive a constant predetermined inspiratory oxygen FiO2, for example, like nasal catheters. So as the respiratory parameters change, as the breathing parameters change, this too shall change. So now your nasal, coming to your nasal cannulas. So the nasal cannula is available as either nasal cannula is available as either a blinded soft plastic tube with an over the ear head elastic band, or it is available as so basically, first, how will you describe any one more thing I have to tell you. How does this FiO2 vary with the variable performance device? With these variable performance devices, the FiO2 will vary a lot, right? So it depends on the breathing pattern of the patient. So when you give oxygen therapy, there is a pooling of oxygen in the anatomical reservoir of the upper airways at the end of exhalation. The oxygen collected in the anatomical and the equipment reservoir is available for the next inspiration. The anatomical reservoir, the nose and the pharynx, is 50 ml mass space is 50 ml. So the nose and nasopharynx is 50 ml. The mask space varies from 100 to 200 ml, and reservoir back, if present, the volume is around 600 to 1000 ml. Depending on the reservoir capacity, it may or may not be able to meet the tidal volume demand of the patient. If oxygen flow rate is constant, then FiO2 will be low. If the respiratory rate, tidal volume, and peak inspiratory flow rate are high. So, okay, I hope you all understood that at the end of inspiration, at the end of exhalation, some airway remains in the reservoir bag as well as the oropharynx, and when breathe during the next breath, that's when the air gets entrained. So first, whenever you describe an oxygen therapy device, first classify the device according to the flows, that is low flow or high flow. The performance of the device, variable or fixed. And the capacity of the device, no capacity, low capacity, medium capacity, large capacity. Then give a brief description of the device. When is the FiO2 delivered? Where it is used, what are the advantages, what are the disadvantages and limitations of the device, and how the device can be sterilized. So this is how you have to go about explaining about a this is how you go about explaining. So the nasal cannulas are low flow variable performance devices. So they are low flow variable performance devices. Now what is this low flow system? So low flow is oxygen therapy devices are classified into high and low flow. So depending on the total gas flows that are delivered to the patient, uh, low flow systems deliver oxygen at flows that are less than the patient's inspiratory flow rate, leading to air entrainment. As a result, this inhaled oxygen concentration may be low or high depending on the device and the patient's inspiratory flow rate. As oxygen delivery of low flow system varies with the patient's inspiratory flow, they are also classified as variable performance delivery systems. However, an anesthetic breathing system which has a tight fitting mask and a reservoir is low flow system which can deliver a known FiO2. So variable is they are low flow because low flows are required. At low flows they entrain the surrounding air and hence dilute the oxygen. So the nasal cannula, they are low flow variable performance equipment. Uh, they consist of two soft prongs that arise from the oxygen supply tubing. blinded ended soft plastic tube with an over the head elastic band, or a dual flow with under the chin lariat adjustment, right? The prongs are inserted into the patient's anterior nas, and the tubing is secured to the patient's face by an adjustable strap. That is number A. A blind ended soft plastic tube with an over the ear head elastic band. The prongs oxygen is delivered through the cannula but at low flow rates, only low flow rates between zero point 0.5 to 5 liter per minute. The patient's nasopharynx acts as an anatomic reservoir, and when the patient inspires, the oxygen is diluted with room air. Again, the degree of dilution depends on the patient's inspiratory effort, and the resulting FiO2 depends on the flow rate of oxygen, right? So the degree of dilution, the amount of dilution depends on the inspiratory effort. Sorry. And the resulting FiO2 depends on the flow rate of oxygen. So the resulting FiO2 depends on the flow rate, the minute ventilation, inspiratory flow, and the volume of the nasopharynx. The FiO2 cannot therefore be precisely controlled because it is involving so many factors like the patient's breathing, respiratory rate, the nasopharynx, the minute ventilation. So too many factors are involved. So it's really not possible to control it. Um, but the maximal tracheal FiO2 is not likely to exceed 0.4%. Mouth breathing causes inspiratory airflow. This produces venturi effect in the posterior pharynx, entraining more oxygen from the nose. So mouth breathing causes an inspiratory flow rate. It produces a venturi effect in the posterior pharynx, which entrains more nas. So flows of 1 liter per minute, FiO2 is approximately. So sizing is available for adults, children, and infants. Cannulas are connected to flow meters with a small bore tubing and may be used with a bubble humidifier. Adults, children, and infants. Advantages are the cannula can be rapidly and comfortably placed on most patients. So comfort. Then ideal for claustrophobic patients. So it's ideal for claustrophobic patients. It allows speech and eating and drinking. The appliance is well tolerated. It can be used for long-term oxygen therapy, most commonly used as nasal cannula. So it humidifies air, ideal for oxygen-dependent patients requiring small amounts of oxygen, and amount of oxygen, especially at home. So now some of the disadvantages are. Some of the disadvantages are unpredictable FiO2, maximum estimated FiO2 0.4, respiratory distress. So any change in the patient's respiratory pattern can cause air entrainment and dilute the cause fluctuations in the FiO2. Then prongs are difficult to keep in position, especially in small infants. Use may be limited by the presence of excess mucus, drainage, mucosal edema, or deviated septum, and maximum flow should be less than 2 liter per minute in infants and newborns. So factors that affect the actual FiO2 delivered to adults by nasal cannula is the actual FiO2 delivered by adults with nasal cannula is determined by oxygen flow, the nasopharyngeal volume, the patient's inspiratory flow, which depend both on pulmonary volume and inspiratory time. So this is very important. It depends on the patient's inspiratory flow. More inspiratory flow, more dilution of okay, and so any change can cause air entrainment. Now, so equipment related to potential harm is improper insertion can cause gagging and nasal of the so there can be mucus, so any gagging and nasal because of any gagging sensation uh, because of local obstruction, because of excessive oxygen flow can produce pain in the frontal structures. It can cause drying of the mucosa. Mucosal inflammation can be seen. Skin irritation may result from maternal use to secure the the cannula, or from local allergic reactions, occlusion of distal opening way. Now excessive flow may cause gastric distension. So because of too much of flow, there can be gastric distension, occlusion of distal openings may occur, skin irritation may occur, drying of the secretions may occur. So there can be skin irritation, excessive secretions can occur, excessive oxygen flow can induce pain. So nasal cannula flow and FiO2. Nasal cannulas can be expected to provide an FiO2 of up to 30 to 35 with normal breathing. And oxygen flows of 3 to 4 liter per minute. So the when using nasal cannula, ideally 2 liters of oxygen is kept, but even 3 liter can be kept. Now FiO2 levels of 40 to 50% can be attained with oxygen flows of greater than 10 liter per minute for short periods. So less than 3 to 4 liters per minute gives about 30 to 35. So why nasal cannula flow more than 5 liter per minute is tolerated? So why are we keeping the nasal cannula flow less than 5 liter per minute? So usually flows greater than 5 liter per minute are poorly tolerated because the discomfort of gas jetting into the nasal cavity. It's very cold air that is jetting into the nasal cavity, drying and crusting of the nasal mucosa. That is why the gas is generally kept at less than 5 liter per minute. This is your nasal cannula which sits behind the ear. Sorry. So it sits behind the ear like that. Now coming to your flow meters. flow meter humidifier. So this is the flow meter. So over here the uh, nasal cannula is connected. Even your oxygen mask is connected here. This is attached to the humidifier. It goes into the humidifier. I'll show you in the next picture. This is the rotatory knob to adjust the level of oxygen. So as you can see, that protrusion part goes into the humidifier. I'm sorry, here is where the oxygen is attached. This is your the control which controls the amount of oxygen. And basically earlier water used to be put in these humidifiers, but now no water is put. It is dry air only humidifiers. Now nasal mask, it is a small capacity system. So nasal mask is a small capacity system. It is a hybrid of the nasal cannula and a face mask. Nasal masks have been shown to provide supplemental oxygen equivalent to the nasal cannula under low flow conditions for adult patients. This is a nasal mask. Advantages are patient comfort and compliance. So the patient is very comfortable and there are no pains. Home use for obstructive sleep apnea like BiPAP and CPAP. Oh, I'm sorry. Advantages are two soles can develop around the external nas of for long-term use of the nasal cannula. So along the external nas, two soles can develop on either side. So this is the basically the BiPAP machine that is used, so only over the nose and the strap support. So over here is where the pressure sole can develop. Now non-reservoir oxygen mask is basically your normal oxygen mask. It is a small capacity system. So it is a small capacity system. They are low flow variable performance devices. So they are basically low flow variable performance. They are low flow variable performance devices with small capacity. The pediatric face masks have a low capacity of 70 to 100 ml and adult have a medium capacity. So kids have a capacity of 70 to 100 ml, whereas in adults it is 100 to 250 ml. Okay, so this is the capacity of the face mask. It is a simple non-reservoir mask, disposable, lightweight plastic device that covers both the nose and the mouth. The face seal is rarely free of leak, and therefore patients receive a mixture of pure oxygen and secondary entrainment of air. So rarely it is properly, the seal is proper, so there will invariably be some entrainment of air. An elastic strap is used to secure the mask around the patient's head. So an elastic strap is used to secure the mask around the patient's head. Higher FiO2 can be delivered if the mask volume is increased. Some patients may have a deformable metal which allows the So some mask may have a deformable metal which allows the mask to be shaped out over the nose to achieve a closer fit. So over here, as you can see, this is the deformable metal. This is the deformable metal which fits on the bridge of the nose to achieve a better fit. Oxygen is delivered through a small bore tube connected to the base of the mask. So this is how your small bore tube connected to the base of the mask. The oxygen that gets collected in the apparatus dead space at the end of inspiration is inhaled during the next breath. There is no expiratory pause. Um, alveolar gas may be rebreathed. Alveolar gas may be rebreathed, vented out through the holes on each side of the mask. So the alveolar gas may be vented out or it may be rebreathed. If there is no expiratory pause, alveolar gas may be rebreathed from the mask at the start of inspiration. Exhale mask, which also serves as room air entrapment ports. So simple oxygen mask provide about 60 liters of FiO2, and depending on fit, a flow rate of 5 to 10 ml is usually kept for these nasal. So factors affecting oxygen entrainment of air ratio during face mask ventilation. The ratio varies with the size of the leak, the oxygen inflow, and the breathing and the pattern of breathing. A minimum oxygen flow of approximately 5 liter per minute is applied to the mask to avoid. So for this, a minimum of 5 liter per flow is used. For that, a minimum of 2 liter. 5 liter is used in the mask to avoid rebreathing and excessive respiratory work. Disadvantages are wearing the mask for long periods of time is uncomfortable, speech is muffled, drinking and eating can be very difficult and challenging. So basically it is quick. This is a quick and easy setup. No more than 0.5% FiO2 can be delivered. That is a limitation. And disadvantages are it again has an unpredictable FiO2. Not more than 0.5% can be delivered. And watch for carbon dioxide. Rebreathing can occur with flow rates less than 2 liters per minute, or if the ventilation varies is very high. So FiO2 and flow of non-rebreathing simple face mask. It is difficult to predict the delivered FiO2. Minimum of 0.5% should be delivered, and but it is unpredictable to see how much can be delivered. It is difficult to predict the delivered FiO2 at a specific flows. So during normal breathing, it is reasonable to accept FiO2 of 0.3 with flows of 5 liter per minute and FiO2 of 0.6 with flows of 10 liter per minute. So examples include therapy in post anesthesia care unit and also emergency department. It is not the device of choice for patients with severe respiratory distress who are profoundly hypoxemic, or profoundly tachypneic, unable to protect their airway from aspiration. This is not a good choice. Now there is a face mask, aerosol face mask which is also known as a nebulizer face mask. So nebulizer is basically, it is a variable oxygen, again low flow device with medium capacity. The mask, which large side holes, is attached to a large bore tubing and to a nebulizer, which delivers water and drug in the aerosol form. So it is a medium capacity system. Your face mask, basic face mask, is a small capacity system, but this nebulized face mask is a medium capacity system. So this is a non-rebreathing face mask, and with your nebulizer face mask, there will be a small chamber, a small box here like this, which will be connected over here, and the drug is put into this, and in the form of aerosols it is delivered to the patient. It humidifies gas, and the disadvantage of the nebulizer is noisy, unpredictable FiO2, and maximum FiO2 estimated is 0.5. This was basically designed for patients with tracheostomy, because the little canister can be removed and attached to the patient who are on mechanical ventilation in the ICU. So this is a non-rebreathing simple face mask. Now coming to reservoir masks, it is a high oxygen, low flow, variable performance device. So it is a so they are low flow, high variable performance, and high O2 devices. So there is a reservoir bag attached to the face mask. See, as you can see here, there is a reservoir bag which is attached to the face mask, right? The oxygen tubing is connected below that. Oxygen flows directly into the reservoir bag. The flow rate of oxygen is adjusted so that the bag remains completely or partially distended throughout the respiratory cycle. The patient inhales oxygen preferentially from the reservoir. If the reservoir empties during inspiration, then ambient air is entrained from the vents in each side of the body mask if necessary. So the flows are set so that the bag is always inflated to some extent. The patient basically inspires oxygen from the bag, and if the bag collapses, then the patient will entrain air from the surrounding. Oxygen delivery can be maximized by using a mask with a oxygen delivery can be maximized by using a mask with a good fit. So any mask with a good fit, oxygen delivery can be maximized. FiO2 varies depending on mask fit capacity of the reservoir bag. So FiO2 will vary depending on the mask fit and the capacity of the reservoir bag. There are two types: partial rebreathing and non-rebreathing mask. So basically the reservoir face mask is classified as partial rebreathing and non-rebreathing mask. So now coming to that. So incorporating a gas reservoir is a logical development to the simple face mask. Two types of reservoir masks are there: partial rebreathing and non-rebreathing masks. Mask reservoirs commonly hold approximately 600 ml or less. So the term partial rebreather refers to part of the patient's expired ventilation refilling the bag. So it is a simple mask with a reservoir bag. Oxygen flow should always be supplied to maintain the reservoir bag at least 1/3 to half full on inspiration. The reservoir receives fresh gas plus exhaled gas approximately equal to the volume of the patient's anatomic dead space. Okay, so the term partial rebreather because the patient expired receives fresh as well as expired. Okay, and this expired This totally is equal to the volume of the patient's anatomic dead space. Usually the gas is largely dead space that should not result in significant rebreathing. So it is just a dead space gas and it will not result in rebreathing of carbon dioxide. The oxygen concentration of the exhaled gases combined with the supply of fresh gas permits the use of low flows than those necessary for other devices. So because there is some mixing of the fresh gas as well as expired gas, low flows can be kept. So a flow of 6 to 10 liter per minute the system provides around, so 6 to 10 liter per minute the system will provide a saturation of 40 to 70% oxygen. The non-rebreathing mask uses the same basic system as a partial rebreather but incorporates a flap type valves between the bag and the mask and on at least one of the mask's exhalation ports. So there are flap valves between the bag and the mask and at least on one of the mask's exhalation ports. Inboard leaking is common and room air will enter during high inspiratory flows even when the bag contains gas. There is no mixing of exhaled gases. Basically with this there is no mixing of exhaled gases with the, so the advantage is there is no mixing of exhaled gases and fresh gas. So there is no mixing of exhaled gases and fresh gases. A series of one-way valves ensures a fresh oxygen supply with minimal dilution from entrainment of room air. The one-way valve over the reservoir bag prevents entry of expired gases and the one-way valve over the side ports limits entrainment of room air. So this limits room air from entering and this limits expired gas from going into the reservoir bag. As the flap valves are on the outside, they do not impede exhalation. This design provides a higher FiO2 than simple and partial rebreathing mask. There should be a minimum of 10 liter of flow is required with these systems and it delivers around 75 to 90% of oxygen at when the flows are 12 to 15 liters per minute. So the lack of a good facial seal may be a disadvantage. A relatively small reservoir which can affect delivered oxygen concentration. The key factor to successful application of the mask is to use sufficient flow of oxygen so that the reservoir bag is at least 1/3 to half full during the inspiration. So it has to be at least 1/3 to half full during inspiration. So typical minimum flows of oxygen are 10 to 15 liter per minute for a partial rebreathing mask. Well-fitting partial rebreathing mask provides an FiO2 from 0.35 to 0.6 with oxygen flows up to 10 liter per minute and FiO2 may approach 100 but usually no, the FiO2 is usually 40 to 70 with inlet flows even of 15 liter per minute, but with 6 to 10 liter is usually 40 to 70 and may approach 1 with inlet flows of 15 or more and ideal breathing conditions. The indications for a reservoir mask. So patients suspected of significant hypoxemia with normal spontaneous minute ventilation such as patients with trauma, myocardial infarction, carbon monoxide poisoning. So patients suspected of severe hypoxemia with normal spontaneous, so normal ventilation but they have hypoxemia. Like some patients who come with MI, carbon monoxide poisoning, trauma, it can benefit those patients. So like I said, this is the partial rebreathing mask. What we'll discuss. This is your non-rebreathing mask. So there will be one valve here and one valve will be present here. Right? So these two valves prevent so this prevents expired gases from entering the reservoir bag and this will prevent it, the valves are located on the outside, so it does not impair expiration and it prevents entrainment of room air. So partial non-rebreathing mask, partial rebreathing versus non-rebreathing mask. So these do not have any valves. As you can see in this there are valves. So this is how it will be. The simple face mask, a partial rebreathing mask. This is your Venturi mask which we should discuss, and this is a non-rebreathing mask, right? So this was your low flow equipment which we dealt with the simple face mask, which requires a minimum of, it can deliver only a 0.5% FiO2 and it requires 5 liter, it does not function above 5 liter, 5 liter per minute of oxygen. And as you can see, the partial rebreathing mask requires around 10 liter per minute and can deliver around 0.4 to 0.6%, 0.7%. Your non-rebreathing mask can deliver almost 70 to 90% FiO2 with percent of saturation with 70 to 90 FiO2 with 15 liter per minute. Venturi mask is your fixed performance, which we shall deal with in tomorrow's class. Okay. So that was about today's class for today, guys. This class for today in brief about this class, and tomorrow we will complete this topic. So that's about it. Do use my code SASHA. This is my code, and you can avail a 10% discount. So do subscribe by using my code SASHA and then avail your 10% discount. Thank you, guys. I'll be conducting a quiz in another half an hour or so based on supraglottic airway device. Do log in. Thank you. Have a good day.